time, hopefully. I'm kidding. And today I've been tasked to talk about shock in preterms, and it's our amazing panelist who chose the title Targeted Agents Reducing Global Hypoperfusion in Extreme Preterms. And so we will try to tackle this question, which hopefully will bring home some of the key messages that were outlined by the brilliant speakers that were before me. And obviously I'm having already trouble to make this work. There's no mouse. There you go. Amazing. Good. Apparently I have a website, but I cannot use a computer. Okay, so you can share my slides. I did receive some nearest monitors from Medtronic for research that I did at the children, but will not be talking about nearest today. So my objective is that at the end of this session, the participants will be able to describe the physiological concepts underlying physiologic perfusion and shock, trying to put a focus on our premature babies who are quite vulnerable. And we will also be able to discuss some of the literature supporting the use of certain management strategies of shock in prematurity. So when I was asked to talk about this, that was my first reaction. I said, oh my God, what am I going to talk about? Is there really evidence down there? And then really, Shasya and Stephanie told me, you need to chill and you need to bring the message home to everyone. That's hopefully going to be my goal today. And so when I don't know what to do, I actually turned to my friends. And so I brought this question last week to some of my friends from the overall community on Twitter. And I asked, if you had a baby at 25 weeks that had a relatively uneventful course, is on CPAP 23%, occasional events, but you're calling the bedside and you have trending down numbers of your blood pressure. You do your evaluation, clinical management evaluation, so, good refill, the baby's pink. What do? Do you actually do a fluid bolus? Do you start some cardiovascular medication? Do you do an echo to get more information, or just blatantly ignore it? And I was impressed to hear, some of you decided to just ignore the baby, especially if it's 3 a.m. But many of you actually wanted to get a bit more information about what's the underlying physiology of all of that story. I then switched a bit the case. I said, well, now this newborn is actually showcasing signs at the bedside that there might be some of these key hypoperfusion parameters. So really gray, clamped, cold, a refill of 6 seconds. You've tried giving some fluid resuscitation. What do? I said, by the resident, by the way, because they're on the first phone call. And many of you actually said, what, I think it's time for me to start some cardiovascular medication support, but many actually thought getting a bit more information physiologically may help, trigger some of the key management strategies, which felt to me, well, let's go and dig to see what more information we get from the literature. So we'll try to talk about targeted, we'll try to talk about hypoperfusion, we'll try to talk about preterms. I also like to go on ChatGPT. We talked a bit about AI to get some info. And I think, when we talk about these three concepts, targeted meaning, well, we're aiming to minimize side effects, we're trying to maximize therapeutic benefits, and really we try to address a particular pathway in order to do so. That we want to reduce global hypoperfusion, which means that we want to diminish the inadequate blood flow to organ and tissue of the body, global implying that many of these tissues are being affected. And extreme preterms, I think, are particularly a vulnerable group because they have very immature organs and body systems. And we really don't know if some of the therapies and strategies that we have actually really, respond the way that we think. So, I think we should go back a bit to physiology, and I'll try to bring everything home to some of the key concepts we discussed today. So, shock in general is defined as not receiving adequate supply of oxygen and nutrients to meet the demand, which leads to ischemia, dysfunction, eventually necrosis. And I do like to say that I'm a hemodynamic, enthusiast, but at the bedside, I'm a baby enthusiast. I'm thinking about the brain, I'm thinking of the kidney, the organs, and really it's all of these things that I'm trying to address to avoid causing toxicity and, ongoing damage to the organs. Perfusion is really trying to achieve this matching. And so at bedside, we often think about flow and resistance that equal the pressure, because this is often some of the metrics that we do have readily and quickly. So we did see this equation of BP, cardiac output, and resistance. But what does it really mean, BP equal cardiac output times resistance? Well, BP, we're humans, and we have pulsatile pressures, which means that we have a contraction which injects blood flow and creates a systolic peak. And eventually you maintain pressure in your system because of the tone of the vasculature and the competency of some of the valves that we have. We know that when we use mean blood pressure at bedside, it's actually trying to capture the complexity of all of everything that's happening throughout the cardiac cycle. And we also know that we do have a BP in both the lungs and the system, and as mentioned, some of these shunts may complicate the relationship of the interpretation of this member at bedside. When we look at cardiac output and we think about our premature baby, it's often a function of stroke volume and heart rate. And when we look at stroke volume, we can think that preemies have myocardial immaturity, they're exposed to certain types of medication, sometimes they have asphyxia. They may have issues with preload because you're dependent on your lung perfusion, which may be impacted about the way you ventilate these patients. Maybe you're gonna have a pneumothorax, or you have a lot of cardiorespiratory interactions that you need to take into account as a potential preload agent to your left ventricle. Tachycardia, these babies tend to run at a faster heart rate, which may impair filling. And some of these babies, we know more and more from the literature, have smaller left ventricular size cavity, which may also affect the way you're going to be leading to a good preload to your system. Heart rate is also influenced by the fact that you have immature autonomic nervous system control and also immature hormonal control. So when we look at some of our babies, like the cases that I just mentioned, sometimes you're going to have babies that when you're trying to outline the underlying cardiac picture, they look like they have great cardiac function. Some of them look more like this, where the function has been affected by a process of stress like sepsis or asphyxia. Others may have very low preload and they actually need that we provide a bit more support in terms of volume, while others are presenting a physiology of what we call high pulmonary vasoreactivity and pulmonary hypertension, here with a kid who has a right to left shunt of the ductus. And then finally, we have some of these rare cases, thankfully, like tamponade, but I could have put a patient with pneumothorax or with other types of adverse cardiorespiratory interactions. Resistance, we often think that resistance is like what Dr. DeBoot outlined, in the morning, like we have a switch in and off, but actually the body is very complex. We have brain resistance, kidney resistance, GI resistance, lungs resistance, and when we look at the total peripheral resistance that, takes into account the blood pressure, well, you may have segmental inflammation, autonomic nervous system changes in our preemie that may influence this. Viscosity, if you give, the opportunity of delayed cord clamping or not, if you have growth restriction or not, this may affect that. And then finally, we know that some of these shunts may also impact the total peripheral resistance that you see in your system. Some of these babies may have other effects to the systemic blood flow in the phase like diastole, where they get blood flow stolen into the pulmonary vasculature from the systemic vasculature. And we don't really know the long-term effect of this and if it does have an effect. Dr. Moore spoke a bit the relationship between the heart and the brain and how actually there's really tight zones that we're trying to maintain in terms of cerebral blood perfusion and how this can be impacted by everything we do in the NICU. One of them being also ventilation with high mean rate pressure leading to venous consideration for the return into the right heart. I do like to go back to what Dr. Rudolph tells us. Great physiologist and great book, something that I have at my bedside every night. And so Dr. Rudolph, when I don't know what to do, I open my book and it says, what is the postnatal circulatory changes in premature infants? Well, it was suggested that the level of mean blood pressure can be considered to be normal if it's equal to gestational age. But we're actually told also that this is completely arbitrary and not even confirmed by reliable observation. So what's really the data? So when I was told by my friend panelists, you're going to need to talk about shock in preterm babies, I said, well, I'll go to PubMed, I'll put shock, premature newborns, and see what are the kind of trials we get. And I got 16 results. I'm like, yay, 16. And they were like irrelevant. They were not like results that were like actually, it's like, pentoxifilin, which is great, but it's not really about the management of shock. But I will talk about some key studies that I think are very important and gave us a lot of great information. Dr. Dempsey ran the HIP trial, which was an RCT that had to be terminated because of difficulty to recruit. And they did not find any difference between dopamine or placebo. Now, this was a lot about transitional hypotension, but it was, around the premature baby, so I do felt it was compelling and important to mention. One study looking at fluid telling us that saline is better than albumin. I've rarely used albumin, but I'm happy to know that saline can work in some of our preemies. Methylene blue for septic shock, something we haven't heard yet. Finally, one slide that maybe is going to bring something new. This study actually looked at 50 newborns compared to other 50 newborns with refractory septic shock, and was quite interesting to see that methylene blue helped to some degree increase blood pressure in some of these patients that were refractory to other inotropes and vasopressors. One study by the group in Australia looking at dobutamine and dopamine comparing each other, and showing that actually contractility was not even improved in these preemies by either inotrope, which was quite disappointing for me, who is a strong believer in hemodynamics, to see that in our preemies, actually we probably don't have as much information about the effect of some of these toxic medications. Hydrocort is something that I really like. Please don't go back home telling Gabriel told you to give hydrocort to everyone, although this is what I tell my fellows. But one thing that came out from this study, which was an RCT looking at placebo or hydrocortisone to complement dopamine, was that actually you're giving less dopamine at bedside to some of these patients, which may be a good thing in the context that in some of these processes, vasoconstrictors might be toxic to some of the organs that we mentioned. Dopamine does reach higher blood pressure when compared to dobutamine, but dobutamine results in better SVC flow, and I just told you that flow and blood pressure may not be equivalent. When you're looking at long-term, because I think that's quite important for our patients, there doesn't seem to be any difference in dobutamine or dopamine for death or disability. And when you're trying to recruit patients nowadays, it's even difficult to recruit them in RCT in the first place. But that should not discourage us to continue to try to recruit preemies in actually shock trials. I'll finish a bit with the epi and milrinone because a lot was already mentioned. This study saw that there was no difference between epi and dopamine in the context of a trial for cerebral NIRS or achieving higher blood pressure. When actually we looked at the side effects, epinephrine had more side effects than dopamine in some of these babies. So lower bicarb, higher lactate, higher glucose, and really no difference in clinical outcomes. They looked at the long term for this population, and there was also no difference. The milrinone in preemies, as mentioned, could be quite erratic because we're always worried that there's going to be accumulation of the drug. And here there was no difference in blood pressure, IVH, or death in a prophylactic trial for milrinone. So that's the data. And what I think I retained from a lot of what I've learned today, thanks to brilliant colleagues that preceded me, is that we're back to what we need to do in terms of approach of management. A lot of it comes from physiological assumptions and observational data that's been outlined before me. And so I do want to bring back to one article, and Dr. Giesinger, I think if some of you were at the neonatal hemodynamics, there was a tribute to her. She did a lot of work for the neonatal hemodynamics community, and I do want to dedicate part of this talk to her. She outlined, that at this point we do know that there are various phenotypes for some of our vulnerable preterms, and until we have more convincing trial about what's a better or what's a strategy that will be, improving outcomes, that at least we can manage these patients with the best evidence that we have. And so she does provide algorithms, and we're going to go through every single box. I do think that it's a good paper, and it provides food for thoughts to bring back and also to outline some of the knowledge gaps that we have that we need to better study. Again, you've seen this slide. It's an important slide to try to, look at the different effects of some of these drugs and what we currently know from some of the observational studies that we have. I did try for my last slide, I promise, to summarize some of these concepts. So we talk about the effect on the vascular resistance of the system and the effect on the support to the cardiac contraction. I did put steroids in the middle. As you can see, I have no bias. And so, you have on one hand side the approach to increase, your SVR, but also to increase your anotropy. You can also work mostly on your systemic vascular resistance if you have, a loss of this vascular tone in your system. You can actually work mostly on your anotropy, but there are caveats and side effects to some of these drugs. And finally, there's also the aspect that some of these patients might have hypertensive crisis or hypertensive phenotypes, and that you need to address this. Now, I do want to remind everyone, we don't have a lot of data in preterms. And I think when you come at bedside, what's important is to avoid polypharmacy, reassess what you're doing, and make sure that we're not causing more harm to some of these babies. We need to be humble about this. We need to make sure that we get more data before we can promote particular approaches. It was outlined there's an ongoing Canadian study of which our site is thankfully joining for getting a bit more sense about what to do about this question. And so for my conclusion, I think that shock and prematurity remains understudied, and we do need more trials on the topic. I think that my colleagues also brilliantly outlined that premature infants and other neonates we do care in the NICU are not just small children. They have very particular cardiovascular inherent particularities. They're going through an important transition. They have myocardial immaturity. They have autonomic nervous system control immaturity and different responses to therapies. I think blood pressure and perfusion are not necessarily the same, and I hope you're going to keep this concept going back home. And I think gentle hemodynamics with selective approach based on physiological phenotype is probably what we have the best so far. I'll finish by saying that I do think we need to have more studies looking at what's meaningful outcomes, neurodevelopment, brain outcomes, quality of life, survival, what cares for parents. And I think some of our trials should look at that as we're moving forward. So I hope you feel more like this than like this. And I'm open for questions, comments, or insults, and the QR code for my website is here.